Next, I'm excited to hear from Dr. Randy Phelps. She's a licensed psychologist with the Division of Psychology at Phoenix Children's Hospital. She specializes in the diagnosis of autism spectrum disorders. She's an assistant professor at the Department of Child Health at the University of Arizona College of Medicine in Phoenix. Dr. Phelps received her bachelor's degree in psychology from Montana State University and master's and doctoral degrees in clinical psychology from Miami University in Ohio. She then completed her internships and fellowship training in autism spectrum disorder and anxiety disorders at Oregon Health and Science University. Dr. Phelps has worked with children on the autism spectrum as well as children with a wide variety of neurodevelopmental differences and mental health conditions, primarily within the hospital setting and academic medical centers. So Dr. Phelps is dedicated in increasing access to evaluation and therapies for families impacted by neurodevelopmental disabilities through community engagement and interdisciplinary collaboration, and is also a very big part of our own neurodiversity committee here at Phoenix Children's Hospital. Turn the time over to Dr. Phelps.
Am I working? Yeah, okay. Well, I'm really excited to be here. I am really thrilled to talk about one of my areas of passion, and this is trying to provide more individualized care to our patients who are experiencing autism as well as other types of disability. I don't have any financial disclosures, unfortunately. However, I do want to be very clear that today I'm not going to be providing any groundbreaking or strikingly new information. What I'm hoping to do, though, is provide a little bit of a framework for providing more individualized recommendations for patients that are coming through your clinics. Before we get into the details and content, I want to make sure that we are on the same page in terms of what we're talking about and the terminology that I'm using today. There's no universal way to talk about autism. A lot of families, a lot of patients who have this diagnosis have differences in the way that they prefer to be talked about. And so some families will prefer a person-first language approach, which would be a person with an autism diagnosis. And other families might prefer an identity-first language. And what we're hearing from a lot of autistic adults who've been able to share their own perspectives and get that across is that an identity-first perspective seems to be a preference in the majority. So today what I'm going to be describing and kind of talking about, I'll be using a lot of identity-first language, but also kind of balancing the person-first language with that to respect both sides of those preferences. A lot of our work today is also going to be rooted within the medical model of disability as well as the social models of disability. And those sound very disparate, and I'll describe why, but I think that they can coexist. The medical model of disability really is identifying and highlighting the deficits that one experiences and where we can provide intervention. Whereas the social model is really thinking more about societal areas where we can provide accommodations and modifications to increase acceptance and one's success within an environment. And I think both of those things can go together. And so today what I'm hoping to do is demonstrate a way in which those things can fit, where we can highlight and celebrate autistic individuals and their differences, while also recognizing that there are areas of support and areas of deficit that require intervention. So to prime our conversation, I'm hoping to talk a little bit about the historical and current whys of why we provide certain interventions for autistic individuals or recommend them. And then we'll identify what some of those common interventions recommended for autistic youth are, both with and without co-occurring conditions. And again, hoping to provide an enhanced understanding of how to provide those individualized recommendations and further empower our families to be active members of their healthcare. Throughout history, individuals with disabilities and autism have been misunderstood, undervalued, and dehumanized. And within that, most of the time, individuals who've had some sort of disability throughout history, the interventions that we've recommended have really been related to making them appear neurotypical or make them as normal as possible. And within the name of making someone's likelihood of increasing normalcy, a lot of aversive and punitive strategies have been used throughout history. Some of those strategies for autistic people include abusive strategies, the use of powerful medications, experimental procedures. And this has been further complicated for families throughout history when we think about some of the kind of blameful and scientifically inaccurate theories that have been put forth that then put blame on parents in how autism might be their fault or how they've caused autism. I say that those things are historical, and yes, they are, and they continue to exist today, though I really think that we're doing a nice job in making some strides in our understanding and celebration of neurodiversity, while also recognizing that people do experience difficulties. There are some aspects of autism that are beautiful and some that are not. And so we want to make sure that not only are we celebrating neurodiversity, but we're recognizing and not dismissing difficulties that people are experiencing. We also are recognizing more and more that a person with autism is not going to look the same when they're 3 as when they're 23. And we recognize that autism and their functioning over time is dynamic. Not only is it dynamic within a person, but it's also dynamic across people. And so what we want to do is provide individuals with more individualized care that is flexible as children grow and meets their needs. So when I work with autistic patients, I tend to take a pretty balanced and evidence-based approach to really understand where they're coming from, so that within their own unique characteristics and set of circumstances, we can promote an inclusive environment. And because autism is highly variable, as Dr. Raz described, recommendations can never be based off of one piece of information. It cannot be based off of a diagnosis, but rather what that individual person needs and requires. So here we have this lovely slide again, which I really enjoy because it highlights not only these characteristics of autism occurring, but also sitting on top of other areas of functioning like our intellectual skills, our adaptive functioning, and the co-occurrence of other potential neurodevelopmental disorders, medical conditions, or mental health conditions. And this is all occurring within a single person. We also know, though, that a person exists within systems. This is Bronfenbrenner's ecological systems theory model, and this describes that a single person really exists within a lot of different systems that bidirectionally influence one another. If we think about this orange circle up here as an individual child, we can see all of these other systems that are going to impact them in a variety of ways. The most proximal circle here, this microsystem, this includes their family, their school, but it also includes their medical home. And I think that's really special because that's an opportunity where we can provide a really nice set of supports and honestly have a crucial role in someone's well-being. Not only is this important because we play a role in that, but that also means that the medical home sits within their own cultural context, and that cultural context is impacted and impactful for the child. And why this is important is because we want to be providing recommendations that are ecologically valid for that family. That means that our ideal recommendations sometimes might not be effective for that family. They might not be accessible, they might not be available, and they might not be aligned with that family's values. So that means that we also need to be really flexible in providing our recommendations and have a wide variety of recommendations to kind of pull out when families feel like something isn't matching for them. This is a pretty bare bones kind of description of different developmental disability services that might be available over the course of someone's life. Dr. Raz talked a little bit about early intervention and that importance. Today, we're not going to have time to talk about some of these other factors like education or state-funded programs, but we are going to spend quite a lot of time talking about outpatient specialty services. And we'll focus mostly on behavioral therapy, social skills training, and individual therapy for co-occurring conditions, with Dr. Raz's mention of medication management. There are all of these other kind of factors too with speech and occupational therapy as well. We're going to first start out by talking about behavior therapy, and there are a lot of different kinds of behavior therapy, a lot of different flavors, and some of them are listed here, but this is a pretty abbreviated list. These can vary between really short-term problem-focused therapies or things that are a little bit more intensive or long-term. Before we talk about some of those differences, though, I do want to get a sense of what your knowledge is and where we stand in terms of how some of you might recommend an intervention. So here's a case. This is completely made up, but pretty consistent with things that I see. So this is Joe. He's a 5-year-old white English-speaking male. He was recently diagnosed with autism and a speech sound disorder. He doesn't have any co-occurring conditions that have been identified. He sleeps and eats well. His cognitive skills are pretty age-typical with some strengths. He does have some adaptive skills delays. And when he comes into your clinic, his parent describes that actually the biggest problem for them are these outbursts that are occurring at home. They tend to occur when there's a transition, when Joe is told no, or when there's a change in routine. And during these outbursts, Joe might throw some objects or hit or kick his parent. And his parent is feeling a little defeated that there's nothing that seems to really calm him down. And these can last 30 to 40 minutes at a time. Some important contextual information, though, is that Joe is doing pretty well at school. He has an IEP for autism, he does well academically, he has occasional outbursts or meltdowns at school, but the teacher doesn't seem to be particularly concerned. He also receives some support services at school, including some explicitly taught self-advocacy skills and some occupational and speech therapies. So with that information, what would you recommend next? Would you recommend that Joe's parent receives just some parenting books about behavior management? Would you recommend an intensive form of therapy like applied behavior analysis or ABA, a short-term problem-focused therapy, or a referral for psychiatry for medication management? One more. No, I'm okay, thank you. Yeah. Nice. Okay, very good. I expected that to be a little bit more mixed, but I'm actually really excited. So yes, I would also recommend a short-term problem-focused behavior therapy. And the reason why is because we actually want to start with the intensive intervention that is going to likely yield the most benefit. And so here, what we're seeing is that Joe's behaviors aren't necessarily pervasive across environments, and we're also hearing, based on the prompt at least, that he probably hasn't participated in behavior therapy yet. So short-term problem-focused therapy would be great. But what is that? So short-term problem-focused therapy is something that is hard to capture, I guess. There are a lot of different kinds of this too. Some of this could be something called parent-child interaction therapy, parent management training. These are therapies that often occur about once per week in a clinic-based setting. Sometimes they can be done virtually now thanks to the pandemic. And these therapies tend to focus on the parent as the mechanism of action. So we're really thinking about parenting behaviors or caregivers' behaviors to then help shape a child's behaviors. There are also other types of behavioral therapy that are a bit more intensive. And these can be things like ABA therapy or an early intensive behavioral intervention, or maybe something that's a little bit more naturalistic. These therapies can vary in their intensity or the amount in which they're structured. So the amount of hours someone receives might vary. And then we're also thinking about kind of how contrived some of these opportunities for learning might be. These can also be done in different environments too. The intensive therapies often are ones that are offered in the home or in a school or in a clinic setting, or maybe even a combination of those things. What they do have in common, though, are some foundational principles that inform how we think about behavior. The idea is that all behavior has a purpose. There's a function behind someone's behavior, and often and always it is a form of communication. We also think that behavior is impacted by one's environment. So if we consider these two things to be true, that means that behaviors are modifiable and that we can learn alternative behaviors to then kind of meet our function or our purpose in the previous behavior. And this is often done through an ABC model of behavior, which describes that there's something that precedes or antecedes that behavior, and then there's a consequence after the behavior. The consequence then informs the likelihood of a behavior increasing or decreasing over time or occurring again. And this should sound pretty familiar if you're familiar with behavior therapy generally, especially if you're familiar with applied behavior analysis, or ABA, which is just an umbrella term for interventions based on operant conditioning paradigms, which is interesting because we talk about ABA as a whole kind of therapy program, which it is, but it is using very specific strategies that are called different things. So ABA previously was really utilizing discrete trial training. It utilizes that still today, but there are some additional strategies that are used within ABA therapies too. ABA has been found to be quite effective for managing and improving behaviors. So improving prosocial behaviors, improving the frequency of which we see desired behaviors. It's also been found to be pretty effective for decreasing harmful or less preferred behaviors, and particularly effective in early toddler years and at high number of hours. That all being said, even though it's effective, we know that not every child requires ABA therapy, that it's not appropriate for every single child. And honestly, I'd be remiss if I didn't take this opportunity to talk a little bit about some of the controversy behind ABA. And ABA itself, because of kind of our historical understanding and how long this intervention has been around for, ABA is something that is not void and has not been void of punitive or aversive strategies and the use of punishment in behavioral shaping. When we think about operant conditioning, this means that we're using reinforcement and punishment paradigms to shape a person's behavior, increase or decrease the likelihood of that behavior occurring again. The term punishment in this context really simply means that we're adding or taking away something to decrease the frequency of a behavior. So this could be something as, colloquial as our typical use of punishment, but it could also be something a little bit more formalized and less aversive. Unfortunately, though, for many years, ABA did use a lot of aversive strategies in order to shape behavior. Our current principles in guiding ABA therapy suggest that these punitive strategies should not be used unless there is a very specific situation and a last resort is needed, and for those situations, there are guidelines that should be followed. More common concerns about ABA therapy and kind of its modernized approach are continuing to be related to the intensity of an intervention. So if we're thinking about something as highly intensive, that means you're spending many, many hours. An example is kind of 40 hours a week for ABA therapy. That means that those individuals are engaging in a specific therapy for a lot of hours. Okay, well, the other piece to this that's a concern is a potential one-size-fits-all approach. Our current guidelines for ABA therapy suggest that there must be an ethical kind of paradigm that follows or the implementation of ABA. So this should be individualized. It should also be following a clinical expertise and that family's value and their own context. So it should not be something that is widely distributed to every single parent, but rather, or every single child, but rather individualized should it be received. All right. We've talked a little bit about behavior therapy. Another really common intervention that is offered for autistic individuals are social skills groups. And with social skills training, we're really teaching social skills quite explicitly. And that means we're thinking about socially accepted learned behaviors that lead to increased skill development and the use of increased skills across various social tasks. And when we think about social skill development or training in early years, that tends to be pretty kind of loosely taught. There are few clearly evidence-based social skills trainings for these really young years, and they tend to become a little bit more evidence-based and curriculum-based as children get older. And in fact, a lot of our research that is being conducted with social skills curricula is in individuals that are school age or older and have average to above average cognitive functioning. So that means that there's a whole group of individuals that we are not really sure how these social skills impact. But what we do know based on some of the literature is that social skills training does impact outcome variables like quality of life, self-esteem, and overall happiness. And before I get too much into this slide, there is an error here. The moderation model that you see here is still going to stand, but I also needed to add a mediation model, which you don't see. So using your imagination, I would love for you to also envision some arrows in a triangle going from social skills training up to our positive social relationships, and then back down to our outcome variables. The reason why this is important is because we're seeing that the use of compensatory social strategies that we learn in social skills training do lead to improved quality of life, self-esteem, and overall happiness for a lot of patients. And this is thought to be occurring through the acquisition of positive social relationships. And this is really important because that frequency of those positive social relationships is a driver of this. And what we're finding too, though, is that the quality of those social relationships matter. If the quality of those social relationships isn't very good, we're not seeing the same outcome variables or the same magnitude in those outcome variables. We are finding that positive social relationships are really protective in some instances from things like peer victimization, internalizing symptoms, and maladjustment. And this all sounds kind of wonderfully positive. Maybe we should all do social skills training and we'd be happier. But actually, unfortunately, I'd like to highlight that internalizing symptoms might be differentially impacted for some individuals when we think about social skills. Before I dive into that, though, what we're going to do is talk a little bit about these common characteristics that a lot of people can experience with autism. So autistic people, as Dr. Raz described, can experience the exact same symptoms and disorders that people without autism can experience. That can be irritability, sleep problems, other neurodevelopmental conditions, and mental health conditions. And because we're learning that some individuals might be differentially impacted, or some of those outcome variables might be different in some autistic individuals, it's really important that we understand how the interventions that we're recommending might then impact our autistic individuals. So here we're going to focus on anxiety and depression and internalizing symptoms, and how our recommendations might then impact those co-occurring conditions. When we use compensatory social strategies, like the ones that we're learning in social skills training, we're kind of learning, or at least practicing, different ways in which we can present ourselves differently in social situations. And this can lead to a pattern of hiding or masking or camouflaging one's own autistic characteristics. So today, the way that masking and camouflaging are going to be used is really identifying this propensity to hide or mask one's autistic characteristics within a social setting. And there are a lot of reasons why someone might engage in these types of behaviors. And these can be categorized into two groups. One of those is conventional reasons. So maybe getting a job or being more successful in your academics. Whereas another reason to engage in some of these masking behaviors might be related to the acquisition of friendships and kind of closeness socially. What's really interesting is that all people engage in some sort of social impression management. What's really important, and what seems to be the most important thing, though, is the extent to which someone does this, and within the context of neurodiversity. The extent to which someone engages in masking behaviors appears to be related to how disparate they feel in their kind of authentic self and their social self that they're presenting. For most neurotypical people, it's quite easy for someone to demonstrate their kind of different selves across social environments. For autistic people, though, it seems to be taking a lot more effort and can lead to mental and physical drain. And what seems to be really predictive of anxiety and depression across research, particularly in young adults and older adults, is this notion of masking. When we think about anxiety and depression for autistic individuals, we know that this occurs. We know it occurs at higher rates too. We also know, unfortunately, that autistic individuals are much more likely to experience suicidal ideation than the general population. And in fact, autistic individuals are more likely to die by self-harm attempts and suicide attempts than the general population. And why I'm highlighting this is because the risk markers, when we look deep into this, at least in the adult literature, is that when we encourage someone to continue practicing social behaviors that don't match with who they are authentically, that really impacts their mental health and well-being. So why this is important for the pediatric population and our recommendations is so that we're able to encourage children to live into their authentic selves while learning skills, while learning different opportunities and tools for success, but that we're encouraging them to use those tools flexibly when they choose to. It is important, though, that not every autistic person has deemed masking behaviors to be problematic or harmful. In fact, some autistic people are describing that masking behaviors have allowed them to have more friendships, more success in their workplace, more confidence in social situations. And for some, this also have kind of identified that increasing their masking behaviors has reduced the amount of bullying that they experience. And that means that for some, masking is actually beneficial in helping individuals. So the idea behind this is complicated. I'm sharing this because it requires a lot of thought, and we don't actually know exactly how this impacts everybody. And so it really begs the question, when you're offering some of these interventions for individuals, for you to track how it's impacting them. And I want you to be regularly screening for suicidal ideation in your autistic youth, and really thinking about how we're encouraging children to engage in some of these social interactions. Okay, so if masking was so problematic for all people, why would we do it? Well, we're hearing that it's not for everybody, but the other piece about this is that indeed it probably was adaptive at some point. There are probably short-term benefits that have become maladaptive over time. So even as you're kind of tracking those youth, just kind of keep an eye, even if it seems to be beneficial for a while. Just kind of monitor that, because it could become maladaptive over time. All right, the last thing that we're going to talk about, since we now know that autistic individuals experience all of the same mental health conditions that people without autism do, we need to know what to do. What are the psychotherapy interventions that we can do? We have a case. Okay, this is Jane. We're going to go through this rather quickly. Jane is a 9-year-old biracial English-speaking female. She was also recently diagnosed with autism and a speech-sound disorder. She does not have any co-occurring conditions, and she sleeps and eats well. She sounds very familiar and similar to Joe. Her cognitive skills are age-typical. She does well academically, and she doesn't have any regular meltdowns. When Jane comes to your appointment, she describes, and her parent describes, that she has a low self-esteem. She's been teased at school. She experiences racism from peers. And her parent denies any clear depressive symptoms. Jane denies any depressive symptoms or suicidality. But her parent wonders maybe if Jane has experienced more bouts of low mood than they know about. Jane does have a prolonged crying, and she sometimes cries when separating from her parent. Jane tells you that she worries that she'll never have friends, and she wants to learn how to make friends. With this information, what is your recommendation? Referral for psychiatry, referral for social skills group, monitor her over time, there are no mental health services required at this time, or referral for social skills group and psychotherapy. I'll open that up. Cool, okay. I'm glad that everybody is kind of on alignment with Dee, but I'm also really interested in and excited to talk a little bit about why B is not a correct response at this point in time. So if we chose B only, we would be addressing Jane's concern about social skills, but we would be missing a lot of the other components related to experiences of bullying and processing of trauma that she might have. So we want to make sure that we would refer for both social skills to meet her need and also address some of these other anxiety and depressive symptoms that might be occurring. Oh, well, let's see if I can go back. So sometimes when we think about some of the treating mental health conditions in autistic youth, the first line of intervention will be behavioral and psychological intervention. Other times it might be medication management, and this does depend on several different factors, including the availability of behavioral interventions, as well as safety concerns and someone's ability to actively engage in some of these behavioral interventions or psychological interventions. Even though we tend to consider both of these separately at some point or another, oftentimes throughout the course of someone's life, a combined approach is needed in addition to the use of other support services, like ones that are available from a state perspective or educationally. I'm going to briefly go through some of the psychological interventions that we think about for autistic individuals. And the type of therapy that we consider is based on our evidence for neurotypical populations. So what are the therapies that work well for anxiety and depression, for example, in neurotypical youth? We're also considering unique patient factors like functioning, the functional impact of their autistic characteristics or their mental health condition, and things like cognitive flexibility. The evidence-based practices that we're considering for neurotypical youth are helpful, yet they do have to be modified. A lot of the common modifications that are used in autistic youth are increased caregiver involvement, as well as an increased emphasis on behavioral approaches as opposed to those more abstract cognitive approaches. We're also thinking about teaching prerequisite skills when those are necessary. And the prerequisite skills that might be necessary could be something as simple as learning an emotional vocabulary. So if you have an autistic patient walk into your room, what I encourage you to do is try to take sort of a standardized approach so that you're able to capture and think about all of the unique and nuanced factors in each patient. The risk that we take without having some sort of model to follow is that we're missing a lot of those characteristics or considerations. So if I were to not step back and identify the goals as well as those individual kind of characteristics or contextual components, I might be missing something really important. I might recommend a behavioral therapy for a family who doesn't actually have access to that. So those are really important considerations, and the more that we're able to kind of follow an iterative process like this in collaboration with the family, the better off we'll be. I firmly believe that partnership and honest and open communication are really, really crucial, and that knowledge is power. And if we can inform our patients and families about what to expect and how to advocate for themselves, they're going to be in a much better position to know when they're receiving evidence-based care or when they need to look for something different. I really think that if we can encourage families to live into who they are and really think about themselves as that expert, as John was describing earlier, we really will have better outcomes. We'll learn more about what works well for families, and they will feel more empowered to be active members of their healthcare. We're learning so much about why we recommend different interventions and how and for who. And if we think about the kind of flexible nature of providing recommendations over time, then we'll be able to flexibly meet our patients where they're at throughout the course of their lives. This is hard. It's really hard to identify what the best recommendation is for a specific person, and we're not always going to get it right. And so what I recommend is taking an approach wherein you can be humble and you can know when you're not sure and you can know when you've made a mistake, and that's okay. I think if we can level with our patients and let them know that we're not sure, they're the expert in this, their child, you're the expert in some of these other components, and working together will meet their need, we'll be at a much better place. Thanks.